We are. All right, all right, all right. Let me make sure and see that it's on here, that we're on. Oop, there we go. Hi, everybody. It's Dr. Linda of the Vascular Birthmarks Foundation, welcoming you all to the November 2023 VBF Facebook Live. Let me see. Oh, I see a couple of you are already jumping on. Let me know that you can see us and hear us. And I'm excited. Yes. And one of the things I'm really happy about is we now have, you'll like this, Dr. Comi, we're having accessibility added to our Facebook Lives so people can read it and hear it. So anyways, welcome Dr. Comi to our Facebook Live. And Dr. Comi is I'm sorry, I don't have my paperwork in front of me. So you are the director of the Sturge-Weber
the Hunter Nelson Sturge-Weber Center at the Kennedy Krieger Institute in Baltimore. Yes.
Thank you. Usually I have that all prepared, but a little COVID brain today as I'm recovering from COVID. So I see that we have people on. So this is our annual Black Friday, where we get together to talk about all things Sturge-Weber. When should you be suspicious of your child or as an adult having Sturge-Weber? Because remember, it doesn't matter what age, you can present with glaucoma later on in life, you can present with seizures later on in life. So there's no blanket, you're never out of the woods for glaucoma, but for the seizures, I believe this is correct, that if you do have proper imaging done at a proper time and it shows clear, then pretty much you can say they're clear.
Right. So, yeah.
So I see that we have 10 people on. Let us know. We're ready to take your questions. We're on for 1 hour. So let us know where you're from and tell us your question. And remember, we can't see images. So tell us where the port wine stain is located, exactly where it is. And if you've had any imaging done, if you've had any eye exams or EEGs or MRIs or anything like that. So I see that we have 10 people on. Let me see. Oh, I gotta turn this sound down. Sorry about that. Okay, hi Kaylee, Antonia, hello. Hi Jennifer, and you're from Alabama. Hi Jennifer from Alabama. Scott is on. Hi Scott. Good to see you. Thank you very much for posting that, Scott, for Dr. Comi's email address. Hi Christy, how are you? So Dr. Comi's on, ready to ask and answer any of your questions regarding when are you at risk for Sturge-Weber, what are the current treatments, maybe what are some of the new researches. I see there's quite a few of you on now. Hello from Texas, Kaylee. Hello from Dublin, Ireland, Antonia. Hello, Cherie from UK. We're happy to see you all. We'd love to hear your questions. Remember that Dr. Comi also will be with me next Friday, a week from today, in Milan, Italy, where we have our VBF Europe Super Clinic, where we'll be doing free laser, free ultrasound, free Sturge-Weber, and free KTS. So we're very excited. It's become quite a huge clinic. So, and hello from Irene. Hello, Irina from, I believe Irina is, I can't remember where she's from, but I've seen her on before. So we're ready to take your questions. I see we have quite a few of you on. Just submit your questions to Dr. Comi. And we've been talking a little bit before she got on, and maybe you want to talk about this while they're typing their questions. Like when you see a baby with the port wine stain and it's in the orbit area or the forehead or along the temple, which is the suspected area. We don't call it V1 anymore. We call it around the eyes, temple, right? And the forehead, scalp, temple. So when you see a baby like that, you can kind of help the parents understand what the risk is, correct?
Right. And we are encouraging families to reach out and be evaluated as soon as possible, because the children who have the capillary malformation or port wine birthmark, the forehead, the eyelids, the temple area, they're at risk for brain and eye involvement with abnormal blood vessels. And we call that Sturge-Weber syndrome. And we want the children, the infants, to be evaluated, their eyes evaluated as soon as possible to see if they've got abnormal blood vessels in the eye, see if they have increased pressure, because that needs to be treated and can cause blindness silently if it's not evaluated, and they have to be monitored every few months in the first several years of life to pick that up, because it can be okay in the beginning. It can be normal for months or years, and then glaucoma can develop later and cause blindness without anyone sort of realizing it. And so that's very important. We want to get those children in as soon as possible. And of course, there's the laser, which can begin in infancy and is very effective for most patients. But also, I'm a child neurologist, and so we want to get them in for the evaluation for brain involvement because for several reasons, because we want the families to understand about Sturge-Weber syndrome. We want them to know what symptoms to look for. Increasingly, we are advocating for monitoring of the very young infants because I've had several patients who have had seizures picked up on home monitoring. And the system that we use most frequently is called OWLET, OWLET. And so that's very important. And then we frequently will refer them for EEG and look at what timing for MRI makes the most sense, depending on what age they are when they get in. And there are complexities there, but we definitely want to get those children in so that they can be monitored, so they can be appropriately evaluated, and the parents have the information that they need.
Okay, well, thank you for that. So Kaylee wants to know, can you tell us more about the GNA11 with Sturge-Weber syndrome? Now, she's saying initial MRI for my daughter as a newborn was clear, but we'll have more follow-up. An MRI doesn't really have anything to do with the GNA11, does it?
Well, so GNA11, so most patients who have typical Sturge-Weber syndrome involvement on MRI have the GNAQ mutation, okay? GNA11, it's called a paralog, which means that it is a different gene, but the protein from that gene serves a very similar function. And so there have been patients who have been reported with Sturge-Weber syndrome brain involvement with the GNA11 mutation, much less commonly. It's much less common, but it seems to also, if it's GNA11, to have seizure activity less frequently in those patients. So it does make a difference. And for the patients who have atypical birthmarks, more extensive, more lacy appearance, reticular, we call it, all over the body, and have hyperpigmentation, meaning sort of purple brown areas of on the body, those patients really should have genetic testing done. And they can start with blood. And if the mutation doesn't show up there, then they should have a skin biopsy somewhere on the body where it's affected to determine whether it's GNAQ or GNA11 or something else. Rare patients actually have some other mutation, and that can be important too, because some of them are associated with increased cancer risk or other things. So if it's very typical, birthmark here, port wine birthmark, no question, not other places. We don't do skin biopsies and extensive genetic evaluations because most of the 90% or so of those patients have the exact same mutation and the exact same GNAQ gene. But if they're atypical features, and we just published a paper about that in the last year, then we do recommend pursuing genetic testing because there's a much higher chance that those patients have GNA11 or something else, and it can make a difference in what we're most concerned about happening, prognosis basically, and what to be most concerned about for those patients.
Thank you for that. Now, Sheza Daly says she has contacted you regarding an MRI her son had. She'd like to ask you what a developmental venous formation involving the hemisphere, probably malformation. No plans to monitor, however, can this develop or change? Also, it was noted his right globe was larger than his left. Does this mean anything?
Yes. So the bigger thing would be the larger globe on that side underneath the birthmark, because that is a sign of glaucoma. So in young children, in infants, where the eye is under pressure, the bone around the eye is actually not fused, and so it can actually enlarge. The eye can enlarge, and the bones around the eye can enlarge. The iris can enlarge. So if the colored part of the eye is enlarging, all of that, it can be signs of glaucoma, and that child should be seen by an ophthalmologist if they haven't already been seen, and right away to have their pressure checked. As far as in DVA, they call it, or deep venous anomaly, that is a vascular malformation. If there's no leptomeningeal enhancement, so if the MRI should have been done with contrast, and if there was no leptomeningeal enhancement, then DVAs can be isolated. They can just sit there, and they're not associated with a very high risk of seizure. But it's also possible that that's the first sign. If the MRI was done very early and the child was just a newborn or just a month or two old, it's possible that that's just the first sign and there is Sturge-Weber syndrome. So I will, when I'm done here, take another look for that email and respond more specifically to that.
Thank you. Thank you for that. Thank you for that, Dr. Comi. Jennifer Vick writes, and Jennifer, I'm sorry, but I already realized you've been told you have a hemangioma your whole life, but it's a port wine stain. And we were actually talking about that misdiagnosis rate. She wants to know can it cause seizures later in life because she's having problems with her head and her left eyesight?
So glaucoma can, and vision loss and issues with the eye can develop in adulthood. Actually, that's the sort of second peak period of time. The first is in infancy and when they're very young, and then the second peak time is in adulthood. And if an MRI with and without contrast has never been done, then it's also possible that the headaches and the head problems could be related to glaucoma. So glaucoma can cause pain, but also it's possible adults with Sturge-Weber syndrome can have big issues with migraine. And so if you've never had imaging, appropriate MRI with and without contrast, then that should be done. About 10% of patients who have Sturge-Weber syndrome brain involvement develop symptoms later. In adulthood or childhood or adolescence. It can even be as they get older adults. So that certainly is possible, and both of those things should be done. The being seen by the ophthalmologist for a glaucoma check and an MRI with and without contrast. And there's a set of sequences that are good to have done to be as accurate as possible with the MRI. And so if people reach out to me, we can send those sequences. I'm also willing to take a look at an MRI and say, yes, has Sturge-Weber syndrome, no, doesn't have Sturge-Weber syndrome. If there are lots more questions on top of that, though, I do need to sort of arrange for the patient or for the family to become patients in some way. So yeah. And there are various options, chart review, in-person visit, and I can do telehealth within Maryland. I'm looking to get licenses in other states so that I can provide care without people having to travel, but that's going to take a little time.
Thank you for that. I'd seen a question, but it disappeared, but I remembered it. And it was from Lindsay, and she was saying if her child was positive for Sturge-Weber at 6 months, should that be repeated, that imaging be repeated?
Okay, so I typically do recommend, I mean, it depends on what was seen on the first image.
Yeah, she's saying to check for further lobe involvement.
Yes, that's right. After a year of age, we
See?
can know the full extent, and that can make a difference in terms of how aggressive to be with management. Because if there's fairly extensive involvement, bilateral involvement, we're going to be more aggressive with treatment than if there's just a single lobe in the back, or occipital parietal, um, more easily managed, less aggressive. If there's very extensive bilateral brain involvement, those patients are at higher risk of stroke and seizures, and we're typically more aggressive. And there are also, becoming new options for surgery and other interventions as well. So, families that, even if their child has bilateral brain involvement, if the seizures are not under good control, they should definitely be reaching out to understand what all the options are.
Thank you for that. Bianca wants to know, I was told Sturge-Weber syndrome is only when the port wine stain is on the forehead or near the eye. Is that true? Because my little one has one on his cheek.
So if it's just on the cheek, it's nowhere like lower cheek perhaps, and it's nowhere close to the eyelids, nowhere close to the temple area, then the risk of eye and brain involvement is quite low. And we would not be as sort of concerned or as aggressive with monitoring and education and all of that. There certainly you would still be concerned about, is it in the mouth? Does it affect the gums? Basically the area underlying that birthmark. However, if it is on the cheek, but close to say the lower eyelid, close to the temple area, to be safe, we would certainly recommend eye evaluations to be certain that the eye is not involved, and certain that the pressures are normal, at least once or twice a year when they're young, and yearly thereafter. And that's not that big a deal to get a eye check, vision check, pressure check once a year eventually, and consider how we would want to check for, or how concerned we would be for brain involvement. But if it's nowhere close, then the risk is very low.
I can see that, because I know there are other kinds of pediatric glaucomas. Mm-hmm. But if we start getting all these people with the port wine stains to go in and get the examinations done, we could really actually be capturing, glaucomas very early that would not have normally been captured. So I really like that idea. So Antonio says, my daughter has a birthmark on the right side, has glaucoma and brain involvement. She does have a blank staring spells. EEG was clear in July. Neurologist wants to put her on Keppra. Should I request further testing before putting her on Keppra? If so, what is the best test to do to determine if she's having seizures?
Right. So the first thing I would suggest, is, because it would be to just interact with the child. And so let's say the infant is staring. They could be zoning, falling asleep, having a bowel movement. All of those can be associated with temporary staring. But let's say the child's name is Jack. If you reach out to the arm and go, Jack, and look right in the eyes, and if they snap out of it immediately, that's not a seizure. Okay. Seizures don't, children go in and out of seizures on their own. You can't startle a young child out of a seizure. And so that's the first thing to try. If you're not convinced that they're coming right out of it, and again, you have to get right in the face and Jack, you're trying to startle them. If you don't get an immediate response and you're not sure, then the next thing is to try to set up a overnight prolonged EEG, maybe even a couple of days, to have the EEG running at the same time as they have the event. And that's the sort of gold standard, really. If the events are happening often enough that you can catch them on the EEG. Even if you don't catch this actual event on the EEG, if they have lots of sharps or spikes developing on the EEG, then you're going to want to, and they have brain involvement. You're going to want to, seriously consider starting medication. If they have brain involvement on imaging, you may want to start pre-symptomatic treatment in any case, because that the first seizure is likely to be prolonged in infants. It's likely to be associated with neurologic impairments, with deterioration or a stroke-like episode, and set the child back. And so, EEG can be used to try to time starting the Keppra, but you can't be doing an EEG nonstop. There's no way to do that. And so it could be okay before and then become not okay. And so some patients and some families and some doctors will recommend pre-symptomatic treatment. And when the family is interested in that, we do that fairly frequently. And levetiracetam or oxcarbazepine and low-dose aspirin is a reasonable combination. And we typically do the combination depending on how extensive the brain involvement is. So if the brain involvement is 3 or more lobes, then, we will offer pre-symptomatic treatment. And if the family is interested, start the combination. The seizure medicine without low-dose aspirin doesn't work. Aspirin without the seizure medicine doesn't work. We know that. The best results so far seem to be with low-dose aspirin and seizure medicine started pre-symptomatically.
Great, thank you. This is a great question from Brooke Atkins. Do you agree that seizures in most Sturge-Weber syndrome babies are more aggressive in the first 2 years of life and through puberty or major growth spurts?
Yes, generally, although, patients are not all the same, and in large part, but not entirely, in large part because the extent of brain involvement can vary from just a small area on one side to the entire side of the brain, to both sides of the brain, to the entire brain. And so there can be huge variability. But yes, generally speaking, the most frequent seizures that are prolonged and associated with strokes or stroke-like episodes are most common in the first 2, 3, 4 years of life. But yes, when they're young, and then can be very stable. And then during puberty, there can be issues again, although it's not usually associated with as long as seizures or as bigger problems as when they were infants. It's just that they can be stable for a decade and then hit puberty. And some of those patients, not all, but maybe a third to a half, will start having issues with seizures again and difficulties, headaches, migraines.
Okay, thank you. This is a great question from Camille. This is my first time to attend such, and this is amazing for parents like me and my husband who have a child with Sturge-Weber syndrome. I've been reading a lot about Sturge-Weber, and I don't know about this MCT oil or CBD oil, but I read it can help with treating seizures with less side effects compared with anti-epileptic medications. We are on a waiting list to see a neurologist in the UK, but wanted to ask you, would this MCT or CBD oil be effective?
So I have used, and it would depend on what the age of the child is. I don't think so. I've used Epidiolex, which is pharmaceutical grade CBD, meaning that every bottle is exactly the same, which is really what you want if you can get it, because otherwise the process for all other CBD can be much more variable. And so the child can be controlled on one bottle and then not on the next because they're not exactly the same. Epidiolex, the CBD is, highly purified, 99% plus CBD, and every bottle is exactly the same. So you know how to dose it, and effectiveness should be sustained. MCT oil, I have not used. I've been asked about it. And the problem with MCT oil or omega-3s or linseed oil or, things like this is that those, we commonly use low-dose aspirin, and those oils can also thin the blood. And so the safety of combining low-dose aspirin and omega-3s, fatty acids, for example, or something like that, or linseed oil. I haven't looked at MCT oil, but I imagine there's a similar sort of issue of sort of combining that with low-dose aspirin and not really being as sure about how much we're thinning the blood and risks, sort of thing. So yeah, that.
Okay, that's good. So Kaylee is saying GNA 11 and glaucoma confirmed, very extensive reticulated staining covering 3/4 of the face, 1/2 of the forehead, and one eyelid. No neural issues so far, 10 months, but 1-year MRI is scheduled. If brain issues are absent, would it still be considered Sturge-Weber or more so DCMO?
Yeah, so DCMO, diffuse capillary malformation,
With
and
overgrowth?
yeah, or there's capillary malformation macrocephaly syndrome. And here's the issue is that if you see the leptomeningeal angioma, the leptomeningeal enhancement on the MRI, that's typical for what we refer to as Sturge-Weber syndrome, then, or the eye exam has not just glaucoma, but the typical findings of enlarged dilated vessels, then some people will call that Sturge-Weber syndrome because the term Sturge-Weber syndrome has been in existence since before we knew about any of these mutations, right? So we first reported the GNAQ mutation in 2013. And more recently, the GNA 11 has been reported by the group in England and then others, including ourselves. So Dr. Kinsler's group. So one way that some people are doing this is to say, my child has GNA 11 related Sturge-Weber syndrome, brain involvement, for example, or my child has GNAQ related Sturge-Weber syndrome, brain involvement, or eye involvement. And the reason that that's important, or at least as we understand it right now, our understanding is growing all the time for what separate, how these are like each other, how they're different. But our understanding now is that a child who has GNA 11 and has the Sturge-Weber syndrome brain involvement, meaning the leptomeningeal enhancement, with in many patients increased deep draining vessels along with that, has an increased risk of stroke. I have seen patients with that, but much lower risk of seizures. So then patients who have GNAQ related Sturge-Weber syndrome brain involvement. And so that's, and then also both can have high blood pressure with them. So that's something, but the patients who had the very extensive birthmark in my experience have a higher risk of high blood pressure at an earlier age, and actually can have abnormal blood vessels around the kidneys. And so that needs to be looked at. The heart should be looked at, so ultrasounds of the kidneys can be done, the heart can be done when the birthmark is involving the chest, is involving the abdomen.
Okay, well, thank you for that. Lisa Ledbetter has a great question. She says, my daughter has a port wine stain on the left side to the back side of her scalp. The pediatric dermatologist told us she does not have Sturge-Weber, most likely. Is that true?
So if the port wine birthmark capillary malformation is only in the scalp area, say along the side to the back, underneath the hair, then that is true. Although if it's large, okay, so extending over most of that side of the scalp to the back, they really should have imaging done once, because large vascular birthmarks that are not small but large can be associated with other structural abnormalities of the brain. It's unusual, it's uncommon, we don't repeatedly image them, but it is recommended that they have one MRI with and without contrast done at some point to take a look at the brain, because they're at increased risk of having various more sort of posterior, not so much the hemispheres, but more cerebellar, posterior fossa abnormalities in the brain. And
okay. So Camilla says, sorry for another question. My son is on Keppra and trileptal. And I read also that these questions just show me how much misinformation is out there, because this question is pretty scary, actually. I read that the side effects of anti-seizure meds are associated with mental and developmental delays. Is that true? And when can we wean a person from taking anti-seizures? Is 2 weeks seizure-free enough time to wean someone?
Yeah, no. Okay. The Sturge-Weber syndrome brain involvement means that they have abnormal blood vessels in the brain, abnormal blood flow to that involved area of the brain, and probably also have abnormal development of the underlying brain, and a very high risk of seizures that is ongoing for the first 2, 3, 4 years of life. And yes, we don't put every child who has just the birthmark on a seizure medicine, because there does work on the brain, and some children have side effects, although the parents can't tell at all that they're on anything. And some animal work has suggested negative effects on the brain. But we know that the seizures cause further decreases in blood flow, particularly in the brains of the babies and young kids, very high risk of stroke, and very high risk of seizures that can last half an hour, or go on for days. And so the goal is to get them on pre-symptomatic treatment that they tolerate well. And so if they're acting normally, eating normally, sleeping normally, and making developmental progress on track, then we leave them on the pre-symptomatic treatment of a seizure medicine and low-dose aspirin. It's certainly for the first 2, 3, 4, I would say the patients that we've weaned off eventually have been patients who were pre-symptomatically treated, and the parents decided at 5 years of age or so that they were interested in coming off the seizure medicine before going to school, and continued the low-dose aspirin and wean the seizure medicine at that point. But at that point, they've been on the seizure medication for the first
Years.
few years of life, not
Yeah.
not a couple of
Not
weeks.
a
That's
couple
not
weeks.
long enough at all. Yeah.
Right.
No.
That's exactly what I thought. Kelsey has an amazing insight. She says, if you don't live near specialists that are familiar with evaluating and or management of Sturge Weber, how do you go about discussing with specialists to ensure correct imaging sequences are done and timelines are completed? When should an EEG monitoring begin and how frequently? My niece is 4 weeks old, has port wine to the right of her eye, the temple, into the scalp, similar to what I was talking about, this area, the high risk area. So that's the aunt that's writing in and about that. And,
So I don't
you
know
know,
where you are or what the availability of non-sedated MRI is, but a child who is under 2 months of age, sometimes even out to 2.5 or 3 months of age, depending on the child, but certainly a month of age, it's appropriate to consider, depending on where you are and availability of imaging, getting a non-sedated, and many places, not all, some places can get non-sedated contrast enhanced imaging done. And you have sort of this brief window of time when the child is very young where sedation does not need to be given, and it's a quick in and out of the MRI. They basically feed the child, bundle them up, put them to, they go to sleep on their own, they stick them in the scanner, and they get the scan done. And it's oftentimes a shortened version, but better than no information at all. And we can look to see if there's focal atrophy, what the size of the choroid plexus is. If they give contrast, then we can look to see if there's a leptomeningeal angioma. And it's not, we know that early imaging can underestimate or even be normal. So it doesn't absolutely rule out brain involvement to get very early non-contrast MRI, but we want this opportunity to try to make the diagnosis before the onset of seizures, before the stroke. And so that is one window of opportunity that's becoming more common as more places are able to offer non-sedated, wrap and go, they call it, imaging. And so that is one thing to be considered for the very young infants. Otherwise, an EEG about every 3 months. So an EEG soon, and then if the child is now a month, at like 3 or 4 months of age, and then at 6 or 7 months of age, that can be done to screen for brain involvement, along with history and exam, and then imaging after a year of age.
Okay. So Irina is from Croatia, and we met her last year at the clinic in Milan. Her 2-year-old son, Andro, who I remember, one of my precious little birthmark babies, he is on trileptal and phenobarbital. And even with therapy, he can have a seizure for over 30 minutes, 3 times this year so far. He does not take aspirin because our neuropediatrician does not agree that he needs it. I am interested in why exactly aspirin is taken and whether it needs to be introduced into the therapy protocol, and how effective are surgeries for children like him. He is progressing very well. There is not much delay, but I'm afraid that if the surgery comes, that will not be the case anymore.
Okay. And it's, there's a lot of complexity there. It's hard to speak to every detail of a particular situation from a brief question like that. But some general information is that we frequently, and I've prescribed low-dose aspirin we're probably talking hundreds of young children and patients with Sturge-Weber syndrome brain involvement now. And it is both a seizure medicine and a medication to prevent strokes and stroke-like episodes. So, it's a seizure medicine in Sturge-Weber syndrome because we have these abnormal blood vessels, and during a seizure, the blood flow goes down even more, placing the child at greater risk of stroke. And when the blood flow goes down, then the seizure risk goes up too. So the seizures and blood flow work hand in hand in Sturge-Weber syndrome in a way that's different from other causes of epilepsy, other causes of seizures. So we do use low dose aspirin quite commonly. And the most common side effects are a little bit of increased bruising. We usually don't see that in infants, but in toddlers, certainly we can see that if it's just along the shins and the forearms from falls and stumbling, then that's not a big deal. We will cut the dose if it's excessive, if they're seeing, more bruising than we would expect in a young child. With regards to surgery, that is an evolving area because the surgeries for Sturge-Weber syndrome are getting safer and safer and safer. And they still, it's still a difficult decision in the sense of if the child doesn't have any delays, really, but the area of involvement and where the seizures are coming from is the motor strip, then any surgery or procedure that's going to deal with the seizures is also going to make the child weak on that side. On the other hand, the parent is right that early intervention, by that I mean in the first few years of life, first 2, 3, 4 years of life, is more likely to give that child time where the brain is very plastic and developing to accommodate to that deficit and overcome it, so that a child who has surgery very, very early in the first 2, 3, 4 years of life is more likely to have less weakness and less neurologic impairments due to that, eventually, due to that surgery, because the other side of the brain is more plastic, more able to adapt in those first few years of life. We don't generally recommend very, very early, meaning in the first year of life, because we don't know if it's unilateral, what the full extent is very, very early, because imaging doesn't always show us the full extent. And also, while it's getting safer, it's still more complex in the very tiny infants. So, although eventually it may head in that direction, but right now we typically wait until after a year of age, unless the seizures are very bad. And, but you don't have to feel like, oh, my child is at 2 years of age, it has to happen now. You certainly could pursue an evaluation so that they can talk you through the risks and benefits and what they would recommend. And is your child a good candidate? It really depends on what the imaging shows. But more children are in the last 5 years or so being offered surgery if after a couple of years of life, their seizures are still not under control despite multiple seizure medicines.
Thank you for that. We have less than 20 minutes left and quite a few questions. I think this is a good one. I haven't heard this before. Lisa says, I've read that vitamin D reduces seizures in people with epilepsy. Would that help patients with Sturge-Weber?
We have a paper out on that, actually. So, if you reach out to me and that's something you're interested in, we can certainly send you our published paper. But yes, 2 or 3 years ago, we published a series of about 60 patients with Sturge-Weber syndrome, and vitamin D deficiency was diagnosed in 2/3 of them. And when we treated the vitamin D deficiency, their neurologic function improved. And so, yes, and seizure control, being on a seizure medicine increases the chance of vitamin D deficiency. Seizure medicines, all of them, can interfere with vitamin D metabolism, which we know is very important for bone and muscle strength. But it also appears to be important neurologically in patients with Sturge-Weber syndrome, and it's quite safe inexpensive. How much to go on depends on what the blood levels are. And so a vitamin D level should be checked, I think, in any patient with Sturge-Weber syndrome, at least yearly. The wintertime is the best time to check it, because that's when it goes lowest in most patients, because you get vitamin D from your diet and from sunlight. But again, even if you're on a great diet, the child's getting great care, if they're on a seizure medicine, then they have a very high chance of vitamin D deficiency, which should be treated.
Thank you for that. Brooke has a good question. Have you seen an increase in blindness or a decrease in eyesight with patients on vigabatrin or vigabatrin? I've heard
Vigabatrin. Yes, vigabatrin.
I've heard mixed things about it, and my 22-month-old is on quite a high dose and has been since he was 8 months old. Would it be difficult to know if it's a progression of the glaucoma or the effect of the drug?
Yeah, so I have not used vigabatrin very much at all in patients with Sturge-Weber syndrome, particularly the babies and very young children. For that reason, we have other options, and perhaps those other options failed in this particular child. So I don't have much direct experience with that at all. It is a potential side effect. We know that from patients with infantile spasms who vigabatrin is an effective treatment for many of those patients, but there is this risk of vision loss that's on the basis of an effect on the retina. And so, yes, one could expect that if you have a child who has glaucoma and is at risk for vision loss from that and is on vigabatrin, it would be very important for the eye. On the one hand, they should be being monitored pretty closely by an ophthalmologist anyway, but they would need to be looking for evidence of issues with the vigabatrin as well as glaucoma effects.
Thank you. This is a great one. In the VBF booklet on Sturge-Weber on their website, it talks about fisting. She wants to know what it is and what does it look like.
Okay. So children shouldn't become handed. Most of us, not all of us, but most of us are right-handed or left-handed. But that really shouldn't start until about 18 months of age. Some people a little bit earlier, some people a little bit later. But a child, an infant who's 4 months old or 6 months old and is handed or fist, so meaning they strongly prefer one hand and keep the other hand mostly fisted and not really opening and closing both hands equally well. Infants should be opening and closing both hands equally well. When they get a little older, they should be batting at objects with both hands, and then they get older still, they should be reaching and grabbing objects, bringing both hands to midline to hold things, and then eventually transferring from one hand to the other and back. If they're not, as they get older, doing those things, but rather keeping one hand or the other hand fisted, then that's what we call fisting or early handedness. And that is not a 6-month-old who's quote unquote handed. That means that they're weak on the side that's being kept fisted more. And so that's not normal handedness. That is what we call hemiparesis or weakness on one side.
Thank you for that. Camille said, my last question is, my son's MRI showed choroidal hyperplasia. I just Googled about it and it says something about increased ICP that causes hydrocephalus. Does it mean aside from Sturge-Weber, my son will also have hydrocephalus?
What is it that the imaging shows?
She said, my son's MRI showed choroid, C-O-R-O-I-D, choroid hyperplasia.
Yeah, no, that is different from hydrocephalus. So the choroid is a structure with special tissue and blood vessels, and it produces cerebrospinal fluid. And it is in the middle of the ventricles, but it is not associated with hydrocephalus. It is not. What it is it is associated with Sturge-Weber syndrome because the the blood drainage normally in the brain is to the surface, and then it's collected in the sinuses and then out to the jugular vein and back to the heart. In Sturge-Weber syndrome, there are abnormal blood vessels on the surface of the brain. And so the blood can't drain out that way very well. So what happens is over time, there's opening of collaterals, blood vessels that drain to the deep venous system. And the choroid plexus is part of that deep drainage system. And so as more blood is draining back to the heart through the deep venous system, the choroid plexus can get larger. And we see that on imaging. And so that is an indicator of possible Sturge-Weber syndrome brain involvement. It would depend on how big it is relative to the other side, and you would look for the leptomeningeal enhancement. Yeah.
Okay, the next one by Brooke is pretty extensive, and she's from Australia. She really wants to know what the difference is between a stroke and a seizure because they don't know much in Australia. And she said when her son, his seizures started, he had 16 days of nonstop seizures. His face would droop, his eyes would go to the side, and his body would almost flop to one side with loss of oxygen. With each one, he would lose part of his ability to use the right side of his body. They don't really have any experts, and no one can understand the difference between seizures and strokes. We have been in the hospital 12 times and almost left in the dark with this.
I would encourage them, if they can, to reach out to me and get a chart review done because there's a lot there to unpack, and there are some recommendations treatment-wise but I would want to make sure that you and your doctors sort of have clear details. And if you decide to go the route of potentially trying alternative ways to prevent these, that the doctors had direct access to me, and we could be very sure that the child was being treated appropriately. The sort of first level of management is aggressive seizure control, aggressive seizure treatment, and low-dose aspirin. But now we have another option beyond that. But again, I would want to make sure that I understood everything about this situation. And if possible, we're communicating with you and the child's physicians.
And Scott's been posting Dr. Comi's email on here for you to reach out or have your primary reach out to Dr. Comi so they can set telemed or telehealth up and communicate about that. We got a couple more before we end. It's going by so fast. I think this is an interesting one from Ashley. She's 53 years old. She has a port wine on her forehead and nose, no history of seizures. But she said, can you develop it later in life? She said, a brain MRI shows abnormal enlarged vessels and Galilean vein primary on the right. Neurosurgeon couldn't agree on diagnosis of MS or Sturge-Weber. She's having some other health-related issues. So she wants to know what your thoughts on if this could really be Sturge-Weber.
So briefly, if you never had, and you probably didn't have imaging done previously, MRI with and without contrast, if this is the first time getting an MRI with and without contrast, then it is possible. And the oldest patient I've ever had present with seizures, first time seizures, was in her 60s. It is possible. And if you arrange to have, you can upload imaging onto a private link, HIPAA compliant link that we can provide. I can take a look and see if I think that this would be consistent with Sturge-Weber syndrome or something else.
Good. Mary Parsons says, my Sturge-Weber daughter, Sammy, had surgery on her face in October. Her birthmark was large and over her eye, and her eye was swollen shut. We live in North Carolina and see a clinic there. She's 50 years old, and my question is, can surgery be performed on her eyelid to help the swelling? She is taking Tegretol and Neurontin for 20 years or so and has had no seizures. Sounds like she might have some overgrowth on the eyelid.
Yeah, it could be overgrowth, in which case, yes, the appropriate sort of thing would be to consider risks and benefits. And I certainly can't say it should or should not be done, but risks and benefits of having sort of and an evaluation would need to be done with imaging of the face to really see what's happening there. The other piece, the simpler piece, if this swelling comes and goes, so they wake up in the morning and the eyelids are swollen shut, and then get out of bed and the swelling goes down and the eye is opening now, then what you can do to sort of help with that is to raise the head of the bed some, and that can reduce some of the swelling that can happen in some patients when they have a dark birthmark that really covers the upper and lower eyelids, and they're having some swelling that's greater in the morning and goes away as the day goes on.
So does that mean there's venous involvement?
Yeah, yeah. So it's impaired venous return, right? And so by raising the head of the bed, you're allowing gravity to help drain that area through the night so that they don't wake up. You know, and it probably is patients who tend to lay on that side, so the eye is down and the blood pools there, and actually can sort of, some of the fluid in the blood vessels can sort of extrude into the tissue, and then they get up in the morning and that fluid gets reabsorbed, and now gravity is helping drain that area again. And
thank you.
so by changing their sleeping position or putting the head of the bed up, that helps to reduce some of that.
Thank you. And the last question I'd like you to answer is, could you speak a little bit? I'm fascinated by the monitors now that the families are using to track the seizures. Are these things that patients buy? Does insurance cover
it is
them?
well, so sometimes not. And you know, increase mostly, honestly, what I see is the price has come down a lot over the last several years, and so but mostly what I see is families just going out and getting it, because they don't want to wait for the insurance companies to approve it or what have you, and they're now, I think they're now like $300, which is obviously, you know, outside the realm for some families, but I increasingly families are doing that. It's a little booty that goes on the foot, and it monitors heart rate and oxygen saturations, and you know, also pick up if just the child becomes really sick at night for whatever reason. But it has picked up seizures happening when the child is not immediately being monitored, which gives families some comfort at night. You know, everybody has to sleep, and so that has been helpful. It doesn't, once a child gets older, you know, they're 2 or 1.5, it doesn't work so well because they just kick it off. But for the little infants, where you're looking for monitoring for the first 6 months, 9 months or so of age, it can be very helpful.
Thank you. Well, we have one more question, and it's 1:58. So this will we'll end with Aiden's question. Aiden says his son had an MRI when he was 7 months old that didn't show Sturge-Weber, but there were some enlarged blood vessels. He's quite short and might be eligible for growth hormone. And I wonder if that might be dangerous and can cause or wake any Sturge-Weber issues or other blood vessel issues. He's 4.5 years old today with no seizures and no cognitive issues.
He should definitely have re-imaging done. Typically, the endocrinologists I've worked with want re-imaging done anyway, because they want to get a good look at the pituitary gland, make sure that there's no benign tumor or growth there. And at the same time, it would be good to also do another contrast enhanced MRI to make sure, because the imaging was done before a year of age, to make sure you know what the situation is with Sturge-Weber syndrome. So imaging should be done, MRI with and without contrast of the brain, and within sections through the pituitary gland. Okay. If they are growth hormone deficient, significantly so, then they won't grow without growth hormone, and would, 4-year-old would need to grow. And so a decision would be made whether they really need growth hormone, or they can sort of wait and see, and the estimated growth might be on the lower side of normal adult height or not, and make a decision there. Yes, I have seen probably growth hormone treatment, if there is Sturge-Weber syndrome brain involvement, has a possibility of destabilizing seizure control. But the bottom line is, if they need it to grow, then they have to have it, and then they just need to be monitored closely for seizures, and if seizures develop, then those need to be treated.
Okay, thank you. Well, it's been a very informative session, and I hope that, and thank you for always volunteering your time every Black Friday. It's better than being out on the road with all those crazy shoppers, right?
Right.
So I
My
hope that
pleasure.
you have a happy holiday season. Merry Christmas, happy holidays, and I'll be seeing you soon in Milan for our clinic there. And thank you for all that you do for the Sturge-Weber community.
Of course. Good to
Thank
see
you.
you. Good talking with everyone. Thank you. And just please reach out if I can help.